Okay, guys, this is chapter 15, gastrointestinal disorders. There's going to be a part one and a part two. We're going to do part one this week, and then next week's going to be part two because there's just so much information in this I wasn't even considering. Um, your next test is only going to be over chapters 13 and 15, and we will just figure out the rest of the chapters and I'll focus on what's most important in those, but we'll talk about that later. So anyway, just focus on 13 and 15 for this upcoming test. All right, we'll get started. All right, so we're just going to do a little A&P review of the GI system. As we know, the GI system is responsible for ingestion, digestion, absorption, metabolism, and elimination. So the upper portion of the GI system is going to be our mouth, esophagus, and stomach, and that's the area that's responsible for nutrient intake. Um, and that's going to handle your ingestion. And then the digestion through eliminations is going to be taken care of through the lower portion of the GI system, which is going to be your small and large intestine. All right, so just to cover some developmental aspects, meaning how the GI system starts out as an infant and just kind of matures up until adolescence. The GI system plays an essential role in a child's growth and development. So you'll see very commonly with a GI disorder or issue that they, especially if they're very young, they have an issue growing, and they're behind on the height and weight, all those scales that you see when they're younger, up to 3 years of age. They're behind on those. So, excuse me. Um, for an infant, there's several things that are in place to ensure that they're adequately intaking the nutrients that they need. So they actually have this posterior portion of the tongue that separates the mouth and the throat, as we have, is actually raised up against the soft palate when they're sucking, and that will allow them to suck and breathe at the same time, so it prevents them from choking. So it's just kind of built in, per se, part of their GI tract, GI system. Also, as we know, the stomach usually empties in 2.5 to 3 hours, so they're going to require more frequent feedings, even more so if they're being breastfed. I mean, that's about the amount of time when they're being breastfed. Like we discussed before, if they have the formula, they tend to last longer. And then, as far as the pancreatic lipase, that all right, so going on to a preschooler, the preschooler will have appetite fluctuations. So they'll have periods where they're overeating and then some periods where they don't want to eat at all. Weight gain about 4 to 5 pounds per year. Things for a toddler that we want to mention, weight gain is about 5 to 6 pounds per year. Growth of a child's digestive system tends to slow during this time, and so that's going to lead to a reduction in the caloric needs that they need. And then the average toddler needs about or approximately 102 kilocalories per kilogram, or also 46 kilocalories per pound. So whatever that is times 46, or whatever they are in kilos times 102, and that's about what they need caloric wise. And because they have the sporadic behavior, they may go on food fads or jags. So they may be preferring one thing at one time, and then something that they did like they'll refuse to have, um, at this time. So they may have loved cheese, and then they hate it the next day. So that's very typical for toddlers to act in that way. School age, the GI system is mature enough for the child to eat full range of foods. Whether or not they will is another story. And then their stools will become more like those of adults, so less frequently throughout the day. And their weight gain is also about 4 to 6 pounds per year. Adolescents, by this time, their digestive systems are adult size and fully functional as an adult. And then yearly weight gain for girls is about 5 to 55 pounds, and for boys, 15 to 66 pounds. Now, obviously, that's going to be when they hit puberty, growth spurts, things like that. I know it seems like a big range, but that's why there is such a big range there. Okay, so next we'll just talk briefly about the physical exam. As we know, particularly with bowel sounds, when you're listening for those or any abdominal exam, you want to auscultate before you palpate, correct? So, with bowel sounds, normal bowel sounds, you hear about 5 to 15 intermittent sounds per minute. That's normal. And then, depending on the type of sound, you can determine are they hypoactive, normal, or hyperactive, or um, obviously, if they're less than 5, but not 0, that's hypoactive. If they're normal, they're 5 to 15. If they're hyperactive, they're more than 15. You'll hear it's like, rawr, rawr. I mean, it's going crazy in there. No doubt, the hyperactive. If you're really going to classify it as an absent bowel sound, you do have to listen technically for 5 minutes in each quadrant to say. Okay, so part one, we're just going to talk about structural, obstructive, and inflammatory GI disorders. The other classifications, per se, if you want to put these in classifications, are the functional malabsorption, hepatic, and abdominal trauma. And we'll cover that next week. So the first three is what we're going to focus on today. And again, bear with me. It's a lot of information, but you guys will get this. They all kind of relate to each other, so you'll see. Okay, so the first section we're going to talk about are the structural GI disorders. That's going to be your esophageal atresia and tracheoesophageal fistula, omphalocele, gastroschisis, cleft lip and palate, inguinal hernia, umbilical hernia, and anorectal malformations. Again, I know it's a lot of information, but I really hit what's the most important, okay? So esophageal atresia and tracheoesophageal fistula kind of go hand in hand. Esophageal atresia, remember that atresia, when you see that word, is the absence or abnormal narrowing of an opening or passage in the body. So either it's not there or it's very narrow. And so EA is failure of the esophagus to develop a continuous passage to the stomach. And it has actually a blind pouch, which we will talk about. I'll show you a picture in a minute. And then tracheoesophageal fistula, or TEF, and you'll see this fairly common in the Peds world. This is an abnormal communication between the trachea and the esophagus, meaning they're connected when they should not be. And both of these are actually associated with polyhydramnios, which is, I think y'all probably learned this in OB already, but it's excess amniotic fluid in the amniotic sac. So normally when the baby's in the womb, they'll swallow and breathe in the amniotic fluid. But if they have a fistula that's very narrow or restricting that flow, the fistula has a hole between the trachea and the esophagus, then it's not going to allow for this. They're not going to be able to breathe in and swallow the amniotic fluid because it's not going to go in the direction, the flow that it should. So the amniotic fluid is then going to build up, and then when it builds up, that's when they get the polyhydramnios. When they do an ultrasound, they may not be able to see a stomach in the baby because the baby's not swallowing the amniotic fluid and the stomach is empty. So that's very common when they do an ultrasound. However, if the fistula is really large in between the trachea and esophagus, then there might be a little stomach bubble of air there, and it looks like a stomach, and then might be misdiagnosed because you really want to get this treated as soon as possible after the baby is born. So they have ways of checking that out to see, hey, is this a TEF baby? Because if the mom has polyhydramnios, more than likely you're going to have a kid with TEF or EA or both. All right, so let me get my pointer. Hold on one second. All right, so over here is a picture, most common types of EA and TEF. So we have just the esophageal atresia right here. So you can see that there's no fistula or any connection between the trachea and the esophagus. All right, this is just the esophageal atresia, meaning nothing formed here. This connection did not occur. Then you have an EA with a proximal TEF. So you see you have this atresia here, but then you get this little connection, this little fistula between the trachea, the proximal side of the trachea, to the esophagus. And then this that I have circled is actually the most common type, EA with a distal TEF. It's about 85% of all cases, actually. So you can see that instead of this connecting to, this is that blind pouch I was talking about, by the way, a second ago. Um, the esophagus connecting to the whole thing connecting to each other, it is actually connecting to the trachea. And so it just went the wrong way. So this is the most common EA with a distal TEF. And then you have an EA with a proximal and a distal, and then you have an isolated TEF where it's just the esophagus is there, but for some reason it decided to make a TEF. All right, so signs and symptoms that you'll see: excessive drooling and secretions, very common. Um, Frothing and bubbling at the mouth and nose because they're not going to be able to swallow these secretions. Cyanosis, respiratory distress for obvious reasons. I mean, more than likely they're going to be aspirating whatever's going in. Choking when attempted feeding, and this happens with every single feed. It's not just going to be one feed, it's going to be every single feed. And then an inability to pass an orogastric or nasogastric tube into the stomach because it has nowhere to go. So it has this blind pouch, so it'll coil up in this little blind pouch. They'll take an x-ray thinking, hey, maybe I got it in there, and they see it coiled up in here, or it'll coil back out through the mouth. So a lot of times it's just chilling out in that blind pouch. So the biggest thing you want to know of these babies is that if you're seeing for some reason it's not caught and you see a baby or in the NICU or you're at a delivery and they're having these issues, check the mother's OB history. And if you see that there's polyhydramnios present, then you need to notify the physician immediately. So if you're caring for a newborn, you're in the nursery, they're drooling excessively and or they're having persistent choking spells or color changes with feedings, and you check that mom's history and you see polyhydramnios, that's more likely going to be a EA or TEF or both. So you want to notify the physician about. Diagnostics, like I said, they'll do a prenatal sonogram, radiology to confirm once they're born, chest x-rays, those types of things. Treatment, maintaining a patent airway and preventing secretion aspiration is number one concern after birth because everything's connected. Because they have that blind pouch in there, that's where the secretions are going to be hanging out and filling up in. And so eventually if they get too much, they're definitely going to go into the trachea, into the lungs, or they're just going to go straight into the trachea, down to the lungs. So patent airway is number one. A lot of times they may have an endotracheal tube in the beginning, but they don't like that because of the TEF, so the esophagus going to the trachea, and with that other one, that one that's 85% where the stomach, the bottom half of the esophagus actually goes into the trachea. If you have an endotracheal tube and you're putting into the lungs, well, guess what? It's going to go into that fistula too, and it's going to cause abdominal distension, which is going to cause more problems. So they really don't want them on an endotracheal tube. They'll try to wean them off very quickly and maybe just get them on some little nasal cannula. But definitely patent airway and preventing secretion aspiration is number one for them. They're gonna definitely have to have surgery. It will be done immediately after birth if the baby is premature, like no doubt. If they're a premature baby or they're in poor physical condition or they have other congenital anomalies, they're going to definitely go straight into the surgery. However, if not, then they may do the surgery in stages. So the first thing that they'll do is they'll close the fistula and attach the two sections of the esophagus back together, and they're going to let that heal, and more than likely they'll have a G-tube in place just to get them feeding, and then once that heals they can start trying to take things by mouth. But you'll see, depending on how long it takes for them to heal or complete the surgery, they may have a oral aversion, so they may not want to take things by mouth. So occupational therapy and those that type of crew will go and help try to get them over that aversion. Nursing care, you definitely want to keep the head of the bed 30 to 45 degrees to promote drainage. Keep the head turned to the side to drain secretions and prevent aspiration, particularly in the beginning pre-op, before they have surgery. I mean, definitely after surgery would not hurt either since they're getting used to that. But definitely want to keep their head turned to the side. Suctioning very gently. Be careful if you start to feel resistance. If you're going in a little deeper, definitely stop. Don't be pushing through thinking that, oh, I'm just meeting a little resistance. Let me keep on pushing through. No, stop if you feel resistance. You may put an NG or OG tube into the blind pouch before surgery because, like I said, the secretions have nowhere to go except that blind pouch. So if you have intermittent or continuous suction there, it'll keep them from aspirating it and it'll just go into the suction tube into the canister. Or you just don't want to irrigate this because obviously the fistula is still in place. And at this time, if you irrigate it, you can get water into the lungs and that would be a big problem. Checking vital signs, of course, and then providing education and discharge instructions. So tell the parents that they need to report um, any difficulty swallowing or refusal to eat after they have the surgery because they may have developed a stricture or a narrowing of their esophagus, because that can happen a lot of times, inflammation, or it's just, their body's just does it. So they may need to get that dilated. So if they see after the surgery and the healing that the child's having difficulty swallowing or not wanting to eat, they need to call their physician and then teach them the signs of respiratory distress. All right, moving on, we're going to talk about quickly an omphalocele and gastroschisis. So an omphalocele is a congenital condition. Intestines protrude into the umbilical cord of the abdominal wall, and it's contained within its own sac covering. So the intestines and everything, so it's the actual umbilical cord. So imagine the umbilical cord going to the placenta. The intestines actually protrude into the umbilical cord, so that same covering that's on the umbilical cord is on this sac right here. All right, so it's like amnion, peritoneum, and Wharton's jelly or something that's inside this sac. All right, so this is actually into the umbilical cord through the umbilicus. Gastroschisis is also a congenital condition. However, the stomach and intestines herniate through the abdominal wall. So typically it's on the side of the umbilicus. So you see the belly button right here. It's on the side and it goes through the abdominal wall. And it's commonly associated with another anomaly. I'm not going to give you specifics on that, but just know typically there's some other anomalies going on with these kids. So you see omphalocele is through the umbilical cord, into it, intestines, and this is the stomach and intestines through the abdominal wall. Nursing care for this kids, you'll have a placement of an OG or NG tube. IV fluids will be replaced by 1.5 times the normal maintenance rate. So whatever the maintenance rate is, you're going to do that times 1.5. You're going to keep the areas covered with a moistened sterile gauze, kind of like the myelomeningocele and the meningocele I talked about in neuro. You want to keep those covered and moist. You don't want them to dry out. The bowel, and typically this is going to be for the omphalocele. The gastroschisis baby will actually have their bowel positioned in this like plastic bag and then in a silo, and the silo actually hangs, and I'm about to show you this in a second. The silo is actually kind of tied to the sides of the bed to hang it over the defect, like wherever it is, like hovering over the defect, and it allows gravity to help kind of push those intestines and stomach back into the body. So you really want to maintain them in a good supine position to reduce kinking of the bowel, because if the bowel kinks up and loses blood flow, that's a whole other issue. So a silo, which I'll show you in a second, actually allows gravity to help kind of push it back in. So the treatment for this is going to be surgery on both cases. It's typically done gradually, but it can be done at once if they're able to. All right, so you can see here, this is a gastroschisis child. The intestines are here. All right, so you can put it in the silo or a clear sheath of silicone. It may have both. a little shear sheath. The one I've seen at Cho is actually this. You have the sheath, and then you have this white thing that's a silo, and it has four. It's on the crib. It's tied to all four areas of the crib to really hover over the body. All right, so let's gravity kind of hopefully push these intestines back in, and then whenever it's done as much as it can, they will put everything else will be put back in by the surgeon and then closed up, and then the baby will be fed probably through the NG tube, OG tube until the intestines heal, or more than likely TPN lipids through their IV until they're able to digest the breast milk and formula again. So that's really it as far as those two are concerned. Try and get my arrow back here. Okay, next is cleft lip and palate. So the cleft lip is more common than the palate is, and that is the incomplete fusion of the oral cavity. I don't have a picture here. This is the palate, but you can imagine cleft lip. Pretend like all this palate right here is fine. Cleft lip can start here and go all the way up into the nasal cavity, or it can just go a little bit. And it can vary in size, and like I said, extend to the nose. Cleft palate is the incomplete fusion of the palates, which you see here. This is an incomplete cleft palate here, so the palate is not fused. Both of these, cleft lip and cleft palate, or if they're together, you can have a unilateral one side, which you see here. This is a cleft lip and palate, or bilateral, complete cleft lip and palate. But if you just have cleft palate or you have cleft lip, it can be unilateral or bilateral. Though actually cleft palate, I mean, it's pretty much one-way street. You'd have to have both to go all the way. But cleft lip, you can have one side or both sides. The biggest thing with cleft lip and palate are the feeding problems. All right, so that's number one for them. You want to make sure that they maintain adequate nutrition and know that they are at risk for aspiration. Those are going to be your two nursing diagnoses for them. They can't create a seal around the nipple, so they're actually bottle fed with a special nipple. This is what it looks like over here. It's commonly called the Haberman feeder nipple. So you can see it goes back further into the throat, so past that incomplete palate, and so they can kind of get a suck on that nipple. Because you remember they have that special thing on the back of their throat on their posterior tongue to kind of help them suck, so they're able to go a little further than normal, especially with cleft lip and palate. You want to make sure, of course, with any baby, they're fed in the upright position to decrease the risk of aspiration. As far as treatment, surgery is concerned, cleft lip is repaired typically between 2 and 3 months, and the cleft palate between the 6 and 12-month mark. And they may require more than one surgery, just depending on how extensive it is. So post-op care for us as nurses, we want to assess vital signs and respiratory effort. If the child does need O2, you definitely want to use a face mask, because think about it, if that cleft lip or palate extended up into the nose, you definitely don't want to be sticking a cannula in there in that surgical site. So face mask if they need O2. Pain management, of course, monitor for signs of infection of the site. You want to avoid the infant sucking on a that should say nipple or passy, and any other objects that might damage the incision site. So until they're healed, they need to be fed through a feeding tube or an IV. Typically they'll have well, you know what? It depends, because if they have if it went up into the nasal cavity, they're not going to have an NG tube, because that would affect the surgical site. So it will vary based on the patient. They could just be getting IV fluids or TPN through their IV. But don't let them suck on the nipple or passy until that's healed. They need to weigh daily. You should actually have a baseline weight on them pre-op, because they are going to be a little smaller than usual since they can't feed well. And you want to make sure that they're gaining that weight and kind of catching up to where they should be. They should have restraints on your child's arm, so no-nos to keep them from touching the incision site. And remember, you got to remove those every 2 hours at least. to kind of give them some range of motion and make sure there's no skin breakdown, all that good stuff. And then assess family coping and support. Make sure they're coping with things well, they have good support. Some parents have an issue with this and can't deal with it very well, so you want to make sure that you're there for them and giving them what they need. Okay, moving right along, we have an inguinal and umbilical hernia. I'm just telling you what they are. Inguinal hernia is actually the most common type in children, 80% actually, inguinal hernias in children. And you can see this here. This is an inguinal hernia, and this is when the bowel, ovary, or fallopian tube actually extends up to or through the inguinal ring into the scrotum or labia. So you have a little ring here. And it goes straight through, herniates through hernia, and then this is where you get the bulge. It's really soft area. And then the umbilical hernia is actually the most common type in infants. So umbilicals, infants, inguinals, children. Those are the most common types. And the umbilical hernia is a protrusion of the intestine through the abdominal fascia. It's very soft. Sometimes it's very big. But if you poke at it, it's very, like it just pokes straight through. And you can identify this with crying, defecation, or coughing. So anything that causes abdominal pressure, you'll see it actually bulge out even more. So that's very common. And then I just wanted you guys to be aware of the different anorectal malformations. Rectal atresia, there's that atresia word again. Closure of the rectal passage is what that is. Rectal stenosis, remember what stenotic is. Constriction or narrowing of the rectal passage. And then an imperforate anus is actually the absence of a rectal opening. And this is where the distal rectum can actually connect to the perineum or GU system. So an early sign of this is passage of the meconium through the vagina, urethra, or an opening under the scrotum. So if you were to see any of this in a newborn baby, brand spanking new, this is a big sign for an imperforate anus. Okay? All right, the next section is obstructive GI disorders. This is going to be your pyloric stenosis, intussusception, malrotation and volvulus, and necrotizing enterocolitis or NEC. So pyloric stenosis or hypertrophic pyloric stenosis, they're both the same. This is actually the thickening of the pyloric sphincter. You can see over here, this is a normal size pylorus, and this is the narrowing pylorus. All right, you see it down here too. Signs and symptoms. The classic sign for this is projectile vomiting. Projectile vomiting, and this occurs immediately after feeding. That's the classic sign for pyloric stenosis. Dead on. They may also have a misspelled appetite, but insatiable appetite because they're so hungry. They're throwing up after every feed, so they're so hungry. So just like sucking on that nipple hard, they're hungry. Weight loss, dehydration, constipation, and visible reverse or left to right peristaltic waves in the left upper quadrant. You can actually visibly see the peristaltic wave in their abdomen, and it's going reverse. So it's pretty interesting to see, but definitely projectile vomiting is the classic sign for this. Nursing care pre-op, we're going to insert an NG tube. You're going to see this is very common in all the surgeries for a GI patient because it's either for decompression, feeding. It's always safe to have one of those in hand in place just in case. Monitor for signs and symptoms of dehydration, specifically because they cannot take in any fluids orally and they're throwing up all the time. The surgery is actually going to be called a pyloromyotomy. Okay, and it's where they actually just do an incision to open up that pyloric sphincter, to open it up wide, and then suture it back up after it's kind of dilated out. Nursing care post-op is common for the infant to experience some vomiting for the first 24 to 48 hours, so let parents know. More than likely these kids are going to be in the hospital still, but if they see this themselves, let them know that it is common to see that. They're going to start clear liquids about 4 to 6 hours after surgery, and 24 hours after the surgery, if they're tolerating those clear liquids, then they can start to slowly advance the diet to formula, breast milk, whatever it may be. And they're just going to kind of take it slow. Safety side note, and this is in red for a reason. You must always auscultate for the presence of bowel sounds before reintroducing fluids or foods. This is after any surgery, particularly abdominal surgery. As we know, everything goes to sleep when you're in surgery, so you're at higher risk for an ileus. So if you start giving them foods or liquids before you hear bowel sounds, then you're going to possibly give them an ileus, because remember, that's where you don't have any peristalsis, and it gets stool and things of that nature can get obstructed because you don't have any peristalsis going on in your bowels. All right, so auscultate the presence of bowel sounds before reintroducing fluids or foods. Ding, ding, ding. Educate parents to monitor urine output. 6 to 10 wet diapers a day. Remember, because we don't want them to get dehydrated, specifically because they've been vomiting post-op. They still may have some issues, so we want to make sure that they're staying hydrated. Intussusception. This is where the proximal part of the bowel actually telescopes into a more distal part. So you can see here we got some telescoping going on. So if it's going to cause an obstruction, which is going to lead to edema in the area that it's in, and then actually if there's edema, that's going to put pressure on the blood vessels and kind of keep them from having regular blood flow, and this can lead to ischemia. All right, it's common mostly in ages 3 months to 6 years. Signs and symptoms, I have stars by the most important ones. These are classic signs of an intussusception. Acute abdominal pain, because the bowel is spasming, you're going to have acute abdominal pain. Infants may start to pull their legs up toward the abdomen. Older kids may too, but it'll be even more common in infants that you'll see this. Pain relief once the abdomen relaxes. And then you may see vomiting, or vomiting will be present. It could be regular or it could be projectile, so it doesn't matter. It could be either or. And then fever, and then stools have red currant jelly consistency. So it's bloody stools with jelly-like consistency. All right, so classic signs: acute abdominal pain, pulling their legs up towards their abdomen, vomiting, and bloody jelly-like stools. Okay. Treatment for this is a barium or air enema. When they actually do this type of enema, somehow the pressure from that can actually cause a telescoped bowel to return to its normal position. However, if this does not work, or this is the second, third time they've had an intussusception, then they will actually go in and repair the bowel through surgery, and then remove any portion of the bowel that has been permanently damaged. So if any of that bowel did get ischemic and die, they will remove that. Next, we have malrotation and volvulus. Malrotation, which you can see right here on this left side, this typically occurs near the cecum. It's a twisting or misplacement of the small or large intestines, typically the cecum, that cut off their blood supply. You have that mesenteric artery, that runs around up in here. And it's actually the most serious type of obstruction. It can lead to intestinal necrosis, peritonitis, a perforation in the bowel, which is a hole in the bowel, and then death due to a volvulus, which is here on the right, which is the complete twisting of the intestine around itself. So you can see oh, this is not good, but this is definitely not good. This can lead to death. I mean, it's a terrible situation. Signs and symptoms: intermittent bilious or green vomiting. This is a major classic symptoms for them. All right, because if you think about it, the cecum is right there at the beginning. So if they're throwing up mainly bile, that's all they can get at this point. They can't get anything deeper than that. So green bilious vomiting, abdominal distension, recurrent abdominal pain, lethargy. You want to watch out for shock, which is tachycardia, tachypnea, hypotension, cool, clammy, cyanotic skin. Because again, if it starts out malrotation and turns into a volvulus, then we're in big trouble. Definitely, excuse me, want to watch for signs and symptoms of bowel perforation. Signs are going to be acute pain over the perforated area that spreads all over the abdomen. And then a big other thing you may see is that in the documentation, the nurse may note that the abdomen is distended with decreased bowel sounds. That's not good. The abdomen may also be rigid. They might have nausea, vomiting, tachycardia, all this stuff. And then mild to moderate pain that worsens with movement. So watch for signs and symptoms of a bowel perf. Surgery needs to be done as soon as possible because we want to save as much of the gut as we can. Resection, they're going to cut off the non-viable intestine. So anything that has been necrotic or is ischemic and is no longer functioning, has that blood flow, they will cut it off, and then they will anastomose it. So meaning they're going to sew the ends back together. So whatever sections they cut off, the viable sections, they will sew them together, and that's called anastomosis. And this could lead to short bowel syndrome, which we'll talk about later. But if too much of their bowel and gut has been removed, then they're going to have very short bowel, and it's going to, food and stuff's going to run right through them. And last for this section, we have neck, necrotizing enterocolitis. So this is an inflammatory disease of the GI tract due to ischemia or hypoxia. So you have ischemia, an ischemic event that happens, death of the mucosal cells then occurs, and then you start getting necrotic patches. So the gut starts to die and slough off, which is terrible, and it smells bad too. Typically occurs in premature infants. Because everything is not as developed in premature infants, and typically it occurs after an infection or an ischemic incident, that they're going to be weary of it. So they're always looking for those little babies. They're watching out for a neck, and you'll hear that a lot when you're in the hospital. Signs and symptoms: tense, distended abdomen, gastric gastric residuals greater than 2 milliliters. And what a gastric residual is, let's say baby's getting a regular feed through an NG tube or even taking formula. But typically it's going to be through an NG tube because that's the only way you can check residuals. So OG, NG tube, baby's getting a formula bolus or a feeding. Prior to the next feeding, you attach a syringe to the end of the tube and you aspirate, pull back on the tube and see how much you get in that syringe. And if you get 2 milliliters or more, then that's meaning that the baby is not digesting that, which is not common. They should be able, you might get a little bit back, but not more than 2 milliliters or more. And it may be different as far as how much is considered too much in the orders, and it will say, check residuals, anything more than blah, 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 contact the physician. But for purposes of testing and you knowing right now, if you checked a residual on a baby and it was greater than 2 mLs, you'd be concerned about neck, especially if they have all the other symptoms. Bloody stools can be common, hypotension, because again, they're not getting blood flow. Things are dying in there, so they could be bleeding out as well into their abdomen. And then poor feeding. It's going to be another big symptom. Diagnostics, abdominal x-ray. This is exactly what it looks like. Sausage-shaped dilation of the intestine. You can see how thick it looks in here. Marked distension of the intestine. Soap suds appear in the intestinal wall. You can see this because there's air if it's perforated and air is getting up in there. And then free air in the cavity of perforation. Well, that's what I was talking about. Same type of thing. So you can see all little areas they're pointing to. This is exactly what it looks like. Nursing care, if you suspect or there's a first sign of neck, you would, stop all the feeds at the first sign. Insert an NG tube. More than likely the baby already has one, but you definitely need one now. They'll also measure the abdominal girth, so you'll get the tape measure and they'll actually mark on the baby where they're measuring to, and that way you can keep a more accurate record, and they'll document the chart every time you measure the girth. You document in the chart to see if there's a pattern or things are growing. Just above the umbilicus, standard is about every 48 hours, but it could be more frequently, and that wouldn't be abnormal. And then monitor their vital signs, of course. And then the only way to fix this is surgery. So they'll go into surgery and they remove the necrotized bowel, whatever is affected, put back together what is not affected, and then they may have a temporary colostomy just for healing purposes. So this is the last section we're going to cover, and this is the inflammatory GI disorders, which is PUD, IBD, appendicitis, Meckel's diverticulum, and pancreatitis. Okay, so PUD or peptic ulcer disease is a variety of upper GI tract disorders that result from gastric acid-related injury and cause inflammation and subsequent ulceration. Okay, so you can see over here we have some ulcers going on. Does not feel too good. And these duodenal ulcers right here are actually more common than the gastric ulcers, like you see over on this side. So duodenal is common in kids. Signs and symptoms are abdominal pain, typically epigastric pain. It's right over the gastric area that worsens after meals, much worse after meals. Dyspepsia, which is also known as heartburn. And then nausea and vomiting. And with vomiting, you have hematemesis, and so that's throwing up blood, because when you have this ulcerations, you may have some bleeding there as well, and so throwing up bright red blood can be common. Not a whole lot, but maybe a little bit. But if it's a whole lot, you might have a bigger issue. Because if with GI bleeds, if it's upper GI bleed, it's going to be fresh red blood that you're throwing up. And then, or that you're throwing up, or if it's stool, if it's an upper GI bleed, it may be darker because it takes longer to get through the digestive tract, because it's going to be a dark black stool. Whereas if it's a lower GI bleed, a lot of times it may be more of a bloody stool because it's on the lower end. It doesn't take as long to come out. But anyway, I digress. Diagnosis: upper GI endoscopy is going to be the most accurate, because this is typically where it occurs. And then upper GI barium radiography may occur as well, but an endoscopy. Nursing care, you may put in an NG tube, and then if they H. pylori, which is very common for PUD, is the cause of it, then you'll give antibiotics. They may also be like on a histamine agonist or proton pump inhibitor as well, either by itself or in as a group. They're all going to be given together. Education, discharge instructions, make sure they're compliant with their medication. Dietary management, they need to keep a food journal to figure out what's really irritating to them, and whatever it is, they need to avoid that. Stress reduction, if there's a lot of stress going on in the child's life, they need to make sure that they're putting a handle on that. And then teach about the importance of avoiding substances that cause pain, such as NSAIDs. You want to avoid those because those can cause even worsening ulcers. And as we stated already, certain foods that they identify. So food journaling is big. IBD, inflammatory bowel disease, is just a broad name for a couple of diseases. Two main ones being Crohn's and ulcerative colitis. So Crohn's is the chronic inflammatory disease characterized by periods of exacerbations and remissions. Okay, meaning you have bouts of Crohn's, flare up, and then you're fine. You're in remission. So you can see that it doesn't take up the entire colon, entire length of the colon. It's just patches. So maybe inflamed, go a little way, inflamed, go inflamed. So it does not the whole colon. It's just patches in the colon. So it's, like I said, skipped lesions of inflammation anywhere in the upper or lower GI tract. So it doesn't have to be necessarily just in the colon, but this is just a picture of what it could look like with the inflamed part. Signs and symptoms are abdominal pain, diarrhea, blood and mucus in the stool, urgency, and tenesmus, which is cramping rectal pain. So the rectum cramps and it's painful and it makes them feel like they have to use the bathroom. So that's where that urgency comes from. And then the sensation of incomplete emptying after defecation. Anorexia and weight loss are common, and typically the onset of this will be between 10 and 20 years old. So kids are usually a little older when they're diagnosed with this. Diagnostics going to based on the history, whatever the physical findings are, and lab results. They'll do an endoscopy and colonoscopy, and then an upper GI series with small bowel follow-up and a CT scan. Treatment, everything for an inflammatory bowel disease is going to be like pharmacological, nutritional, surgical, and psychosocial. Those are the main areas you're going to focus on. Corticosteroids are used, immunosuppressive medications are used, and these are typically used when the corticosteroid treatment doesn't work or if it's resistant to the corticosteroids. So corticosteroids are typically first line, and that kind of helps reduce the inflammation. Anywhere from moderate to severe, could be oral, could be IV, depending on what's going on. That doesn't work, it's resistant to that, then they'll go to the immunosuppressive medications. And then when it's not responding to any other treatment, infliximab or Remicade. Remicade, that's going to be, you probably heard of Remicade before, but this is going to be the treatment of choice for Crohn's if they don't respond to any other treatments. They may also get antibiotics, antidiarrheal agents to stop them from having diarrhea, and then fluid and nutritional supplements as well as needed. There's also research out there that has found that fish oil is actually very effective to decrease Crohn's relapses, so to have them keep them from having flare-ups. And they can have surgery, but let's say if there's bowel that is affected, it will remove that affected bowel, but it's not going to cure them from having Crohn's. So there's no cure from Crohn's. There's only palliative things that you can do to keep them from having flare-ups or having further issues. Okay, as far as education is concerned with Crohn's, they need to have frequent small meals so they're not eating in bulk. They can digest it much better. High protein, high carb diet. Restriction of irritating and poorly absorbed foods, so fried foods and carbonated drinks would be in that category, so avoid those as much as possible. When they have flare-ups, they need to decrease foods that actually stimulate peristalsis, so any type of high fiber food they want to avoid because that actually promotes water retention, which is going to cause them to have more diarrhea. So you want to make sure that they're avoiding those. And then, as I stated already, nutritional supplements as needed to maintain nutrition and growth, especially when in the younger kids, because you got to make sure they're getting what they need to catch up to where they need to be, especially if this has been affecting them for some time and they're just not getting diagnosed. And then they may need a psychosocial referral just because, and as far as coping with the disease is big, and they may face issues related to school absences and tardiness, and they may need special bathroom privileges at school, and you want to make sure you're keeping track of their self-esteem, that they're not having issues with that, because if they've had this most of their life and they're just getting diagnosed, more than likely they're going to be smaller than other kids, or they've been on steroid use for it too. Corticosteroids are going to stunt your growth, so you just want to make sure that you're giving them all the support that they need for that. Ulcerative colitis. This is acute or chronic inflammation of the colon characterized by recurring bloody diarrhea. It actually involves a continuous segment of the colon and involves the epithelial lining as well. So, oh gosh, we're just talking Crohn's was just skipped areas that are irritated. This actually does a whole continuous segment of the colon. Let me get my thing here. So you can see here, you can do the whole segment of the colon. It's not just going to be little areas. Age of onset is typically between 15 and 25 years, so they can be much older when they're diagnosed with this. Signs and symptoms are abdominal pain, bloody diarrhea, like I said, is going to be a number one sign, bowel elimination urgency. Tenesmus, which remember is that's that painful cramping of the rectum, and then left lower quadrant pain with cramping, and then pain that increases with defecation and passing gas. That's a big one. And so treatment for UC is IV or oral steroids just to decrease the inflammation from UC. They may also use immunomodulatory agents, which are also like vitamins, minerals, natural foods, as well as some special medications to help and also wean off the steroids. They also will take iron supplements because they will be anemic due to the hemorrhaging that they have from UC. And then they may also take antispasmodics before meals because meals are going to make peristalsis occur. And so if they take an antispasmodic, things will be more relaxed and they can not have as much of an issue. However, if they continue to have persistent hemorrhaging and the medical therapy is not working, they can have surgery and that actually cures UC. And what it's called is a total mucosal proctocolectomy with the ileal pouch anal anastomosis. It's a very long name, but that's what it's called. So let me get my little thing here. Okay, so you can come over here to this little picture and this is what they do. I just find this intriguing, so I wanted to explain it to you. So they keep the anal sphincter, the original. You can see the small intestine here all the way to the ileum. They cut it off. They remove the entire colon and the rectum. Okay, once that's out, we're coming over here to the first main stage. Colon and rectum are out. They are going to keep this ileostomy, and with the last foot and a half of the small intestine, they create this J pouch, which is going to replace the rectum. They've built a new rectum here, and they sewn it to the anus. All right, so they let this ileostomy stay here until everything is healed, and this is starting to function as it should. Then once it's healed, the second stage is closing the ileostomy site and anastomosing, putting back together, surgically stitching everything back together so that now food and stool can pass as it would normally. And this is your new rectum. So you got this J pouch here. That's your J pouch. And then this is just the side view, J pouch. So you just make a whole new everything. So your entire colon and rectum are removed. It's unbelievable to me, but it's just amazing what medicine can do. Moving on to appendicitis, we know that this is the inflammation of the appendix, and typically it's due to maybe it's being obstructed due to fecal matter or lymphoid tissue, maybe a tumor, some other issues going on. And when it's obstructed, the appendix is going to distend, and then it's actually at risk for becoming ischemic and necrotic, which is not good. So that's how the appendicitis occurs. Signs and symptoms, you'll have periumbilical pain. So this is really right on the umbilicus. And it gets so bad at it'll awaken the child in the night like every 4 hours and then it goes away. And then what happens is that you start having that right lower quadrant pain, which is a classic sign. All right, that's how they're able to tell that this is appendicitis. Then you may see vomiting. They usually lie with their knees bent because with your knees up, it takes that pressure off and it's like, it's just relaxing to them. It doesn't hurt as much. They may have a low-grade fever. If they have a high-grade fever, that could be a problem because they could have perforated. So let's say this came necrotic, fell off. Guess what? Now you got a big old hole here in your cecum. So that's a perforation, and you don't want that because all that stuff in there is flowing out into the abdomen, and that's a big issue. Okay, you have a 36 to 72 hour window from the onset of the pain to the rupture or if it ruptures, you have a perforation of the appendix. So 36 to 72 hours from the onset of pain this needs to be treated and taken out. When abdominal pain, this is kind of hard to see, when abdominal pain is suddenly relieved without intervention, you better be concerned for perforation. So they may have all the symptoms and it's like, it doesn't hurt anymore. Well, get somebody because more than likely they perforated and their appendix ruptured. and they can be septic. I mean, like I said, everything is spilling out into the peritoneum now, and you're losing time, so you got to get them seen. I would know that. Physical exam findings that you'll see: the rebound pain, tenderness, tenderness with the exam in the right lower quadrant. So you're palpating in, you push in the right side, and then when you release it, they have pain. So rebound tenderness. Positive psoas sign, which is pain when you do passive extension of the right hip. They'll start to have pain there in that right lower quadrant. Positive heel drop jarring test. That's pain in the right lower quadrant when they're jumping and landing on their heels. So those are physical exam findings that you can find. As far as diagnosis, the most reliable is the progression or sequence of the symptoms. So just like I said earlier, you have that peri-umbilical pain that typically awakens them at night, then it'll go away, and then they'll start having that right lower quadrant pain, and that's like the most reliable diagnosis. They may do some labs, x-rays, all that stuff, but that's going to be their most reliable one. Again, if they have relief after having all that pain, be concerned for perforation. They're going to have surgery to remove the appendix. Post-op, if they had an unruptured appendix, you're going to monitor vital signs, assess surgical site for bleeding or infection. And then a big one, per usual, is going to be assessing bowel sounds and making sure they function properly. If it did rupture, you're going to have an NG tube there to low continuous suction, just to kind of keep basically they're not going to be getting anything by mouth. They're going to be getting everything through their IV. So if they perforated that cecum area, then you know that you want the bile and everything. You don't want to be traveling down there. You want to give that a rest. So it's going to be continuously suctioning out everything that goes into the gut. Excuse me. Into the stomach. So you'll have that there. Wound care, more than likely, if they have a ruptured appendix, they might have a wound vac, depending on the severity of how much bile and things got into the abdominal cavity. I took care of a girl one time. She had a huge wound vac. She went to a hospital and they just missed it, and her appendix burst and she perforated, and she was so sick. And like I said, you can get so septic and ill. You got to catch this quick. So whatever wound they may have, you'll be doing some wound care. And then assess for signs and symptoms of peritonitis, which they're at huge risk for, which is fever, sudden increase in pain, rigid abdomen, irritability, abdominal distension, tachycardia, and chills. Next, we have Meckel's diverticulum, and this diverticulum, see this little guy right here? It's the fibrous band that connects the small intestine to the umbilicus. All right, so typically it goes away, but this occurs when there's a failure of the omphalomesenteric duct to fuse during embryonic development. And this should disappear, this little guy should disappear between 7 to 9 weeks of gestation. And what it does is when it's in the fetus stage, the baby in the fetus, it connects the yolk sac to the midgut. And so like I said, the duct should fuse, and this should, when it says fuse, that means it cuts this off for business. Should not be around. And it's actually the most common congenital malformation of the GI tract. So 65% of children under 5 have this congenital malformation. It only becomes a problem when it's causing a lot of issues. What you'll see signs and symptoms wise: painless rectal bleeding. More often older kids will have this. Abdominal pain, and then stools with a current red, which current red is what that means, jelly appearance. So those red jelly stools that we don't like to see. Treatment, surgery, if they're having symptoms, well, they will remove the diverticulum. Otherwise, they kind of let it be. And then education, talk about pain management and signs of infection, and then the progression of activity over a 2-week period. You don't want to let them run around too soon, too quick. Next, we have pancreatitis, which is the inflammation of the pancreas parenchyma, which the parenchyma is like the functional tissue that you'll see, so lung parenchyma, all that stuff. So as far as the pancreas is concerned, this is the tissue that produces and secretes all our lovely digestive enzymes, so we don't want that inflamed, but it is. You have acute versus chronic. Acute is a sudden onset, it is reversible, whereas chronic is irreversible. And what it is because it's irreversible changes to the pancreas and its actual overall function. And this is typically, excuse me, due to recurrent or persistent pancreatitis. And a lot of times you'll see this in cystic fibrosis patients because, again, they have all that mucus, so it causes a lot of issues. I guess I like this picture. It's on every slide. Signs and symptoms, they will vary with age, and they're very kind of non-specific, but they'll have nausea, vomiting, which is actually most common in kids under 3, abdominal pain, maybe some abdominal distension, and more than likely they'll be hunched over or have a knee to chest position because that helps with the pain. Nursing care for these kids, management of fluid balance, you want to make sure they're hydrated, any type of nutritional support that they need, pain control. Actually, the one thing that they use to treat pain in pancreatitis are narcotics, but there is a controversy using those because they say that it actually spasms the sphincter of Oddi, which is the opening of the common bile duct into the duodenum. All right, and then that actually can cause further pancreatic inflammation. So you can see we got our common duct right here, so it goes up in here, and then our Oddi, sphincter Oddi is going to be down here, so it can cause a lot of problems, pancreatic inflammation. So you may hear some controversial talks about that. Patient will be NPO, we'll have that lovely NG tube still. Surgery, you're going to do that pre and post-op care that you do with most kids when they have abdominal surgery. And again, the NG tube is going to be for decompression and suctioning for more than anything because they're going to be NPO and they don't want them being fed right now or having extra, stomach juice going around. Okay, and that was that. I did do some review questions for you here. So review question number 1, we're going to do some term matching because you guys got to learn your terms. It's good to know these, especially like atresia, stenosis, things like that, because if you see those, even if you don't know exactly what it is, you have an idea of what's going on. So just match what's going on. So blank, the first one, what is the absence of a rectal opening? Second one, telescoping of the intestine is known as what? Third one, inflammation of the abdominal cavity. Fourth one, the surgical connection of bowel segments. So your options are intussusception, peritonitis, imperforate anus, and anastomosis. We'll move on to the answer. Boop, here you go. All right, so absence of a rectal opening is the imperforate anus. Telescoping of the intestine is the intussusception. Inflammation of the abdominal cavity is the peritonitis, and then surgical connection of the bowel segments is anastomosis. Number 2, what is the classic and most common symptom of hypertrophic pyloric stenosis? A, abdominal distension, B, difficulty stooling, C, projectile vomiting, or D, irritability. And the answer is C, projectile vomiting. Question number 3, a child exhibits episodic abdominal pain, vomiting, blood stools, should probably be bloody stools, and legs drawn up to the abdomen. These findings are a classic triad most indicative of which condition? A, irritable bowel syndrome, B, malrotation, C, volvulus, or D, intussusception. And the answer is D, intussusception. And if you think about it too, if you look at this, if you didn't quite know, these are one and the same. Pretty much. Malrotation occurs first, but it can lead to a volvulus, so that could be confusing. So if you see these together, then more than likely those aren't the answer. And irritable bowel syndrome, we talked about Crohn's and ulcerative colitis specifically, so that would be not a good answer. It would be need to be something more specific. So intussusception by default, if you looked at each answer, would be your answer. But these definitely know this. These are the classic symptoms of the intussusception. 4. Before reintroduction of oral fluids and foods following gastrointestinal surgery in the infant, what is the most critical nursing action? A. Administer medications as prescribed. B. Auscultate for presence of bowel sounds. C. Monitor intake and output. Or D. Assist mother with pumping and storing breast milk. This shouldn't take long because I know you know it. The answer is B. Auscultate for presence of bowel sounds. Remember, always, always, always. You don't want an ileus. All right, and the last question, question number 5. Unlike Crohn's disease, ulcerative colitis, A, has an unknown cause. B, involves a continuous segment of the colon. C, is characterized by extraintestinal and systemic features. Or D, does not have a cure. B, the answer is B, involves a continuous segment of the colon. Because remember, ulcerative colitis does have a cure. And Crohn's and ulcerative colitis really don't have a known cause. They think it's definitely hereditary, but other than that, that's about it. All right, so this is part 1. If you have any questions, let me know. We'll do part 2 next week.